Musculoskeletal Part 1. Osteoarthritis, lower limb joint pain, and medial meniscus tears are the most common musculoskeletal diagnoses. The skeleton serves as a hard scaffold that supports and protects the body's soft tissues and organs. Synovial joints have the most movement of all the joints. These contain ligaments, cartilage, a synovial membrane, and synovial fluid. Some joints have a bursa, some tendon sheaths, and menisci. These are all vulnerable to various infections and immune disease processes. Musculoskeletal disorders. For gerontology musculoskeletal disorders, some of the most common are osteoporosis, osteoarthritis, gout, and frailty. Bone is a hard connective tissue and consists of scattered cells surrounded by extracellular matrix that comprises inorganic and organic components. The matrix of bone is hardened by deposits of calcium hydroxyapatite crystals that consist of calcium phosphate salts, and these align in parallel to the collagen fibers that are predominant in the bone matrix. The collagen fibers give bone its tensile strength, or the ability to resist pulling and stretching forces. The mineral content of bone enables it to resist compression forces to which it is exposed during weight bearing and movement. Bone tissue is produced and maintained through regulated interactions among three various bone cells: osteoblast, osteocyte, and osteoclast. Osteoblasts are derived from mesenchymal cells and are the cells that secrete the osteoid, or the organic bone matrix. When teams of osteoblasts complete bone production, they flatten and form a lining at the bone surface called periosteum. When it covers the external bone surfaces, or endosteum when it covers the internal bone surfaces. The osteocytes extend cellular processes toward other osteocytes through small canaliculi in the bone matrix. Osteocytes help to maintain the bone matrix, modulate the activity of the osteoblasts and osteocytes, and control bone remodeling. Upon activation by osteoblasts, osteoclasts move along the bone surface to the microfracture site. There, the roughed border of the osteoclasts attach tightly to the underlying bone, creating a reabsorptive cavity between the osteoclast body and the bone. The osteocyte takes up the end products of bone degradation from the reabsorptive cavity by means of endocytosis. It moves them in vesicles through the cell and releases the digestive end products across the free surface of the osteoclast into the extracellular fluid. Therefore, it completes the task of bone reabsorption. When bone reabsorption is complete, the osteoclasts undergo apoptosis. Bone remodeling is a lifelong process. After maturation, when linear growth of bones end, the bone is continuously remodeled and strengthened based on the type of stresses to which it happens to be exposed. The process involves the sequential activity of the osteoclasts, multinucleated cells derived from hematopoietic stem cells of the monocyte lineage, and the osteoblasts, which are derived from mesenchymal stem cells. Bone remodeling is regulated by calcium-controlling hormones, such as vitamin D and parathyroid hormones, as part of the total body calcium homeostasis, and it is also influenced by the sex steroids, the growth factors, and cytokines. In postmenopausal women and older men, an imbalance develops between bone reabsorption activity of the osteoclasts and the bone synthesis activity of the osteoblasts, leading to decrease in bone density. A fracture is considered the loss of bone integrity resulting from mechanical injury or diminished bone strength, or both. A fracture can be produced by direct or indirect injuries. Fractures produced by a direct injury result from a direct blow or crushing force. Indirect injury fractures are the result of forces transmitted through the bone to an area of weakness. A simple fracture has only one fracture line and produces two fragments. A comminuted fracture has more than one fracture line and produces multiple fragments. In a displaced fracture, the ends of the bone at the fracture site are not aligned. A stress fracture is a slowly developing fracture that follows a period of increased physical activity where the bone is subjected to repetitive loads. A green stick fracture occurs when the cortex fractures on one side while maintaining the thick periosteal tube. Pathologic fractures occur in bones weakened by an underlying disease process, such as metastatic tumor, osteomyelitis, or osteoporosis. These pathologic fractures are often spontaneous or non-traumatic. Avulsion fractures occur when a tendon or a ligament attaches to a bone. The force of the injury tears off a piece of the bone at the tendon or ligament insertion site. Various fracture dislocations. When a fracture occurs, the rupture of blood vessels from the soft tissues and hemorrhage from the bone itself result in a hematoma. This fills the fracture gap in the surrounding area of the injury. The loss of circulation at the hematoma leads to the death of tissue at the fracture site. Damaged cells secrete inflammatory mediators, and an aseptic inflammatory reaction begins. This is often accompanied by a low-grade fever and a local increase in warmth. The hematoma and edema fluid cause varying degrees of swelling, pain, and ecchymosis. Initially, the fluid surrounding the bone fragments becomes slightly acidic. Osteoclasts, macrophages, and neutrophils are attracted to the area to clean up the cell debris. During this phase, as it progresses, proliferating fibroblasts migrate into the area along the fibrin strands of the hematoma. Capillary elements bud from the periosteum into the hematoma and create granulation tissue, dense with newly formed capillaries, to restore the blood flow to the area and replace the hematoma. The hematoma phase begins within hours after the fracture and may persist for several weeks, overlapping with the next phase of the repair process. During stage 2, the fibroblasts and osteoblasts that have migrated to the fracture area from the periosteum and the endosteum create a gradually more stable connection between the bone fragments. Fibroblasts secrete collagen fibers. These are important matrix proteins for both cartilage and bone tissue. Some cells form new capillaries, differentiate into chondroblasts, and secrete cartilage matrix. Gradually, the acidic pH characteristic of the first stage is neutralized. After 10 to 14 days, the local pH becomes alkaline and the concentration of alkaline phosphatase increases at the fracture site, causing the cartilage matrix to calcify. Ultimately, the bulging fibrocartilaginous or soft callus will completely surround the ends of the bone fragments and form the scaffolding for a more stable, hard callus. In stage 3, the alkaline pH of the interstitial fluid surrounding the fracture site activates the osteoblasts that have migrated to the area, and the osteoblasts begin to secrete osteoid, which is an organic portion of the bone matrix. This is mineralized by the hydroxyapatite crystals. The calcium salts deposit around the collagen fibers to form woven bone. By 6 to 8 weeks after the fracture, bone tissue will have gradually replaced the soft callus formed in the previous phase. The woven bone forms a relatively stable hard callus at the fracture site. Stage 4, as the callus matures and is subjected to weight-bearing forces, portions that are not physically stressed are reabsorbed. This remodeling reduces the size of the callus until the shape and outline of the fractured bone is reestablished as lamellar bone. After several months, the medullary cavity of the bone will be recreated. There is evidence that bone remodeling normally continues at a fracture site for up to a year or more, as the bone continues to adapt to the routine mechanical stress. Pseudoarthrosis, or a false joint, or a non-union, is the failure of bone formation after 6 months, and this is one of the most common complications of fracture healing. Infection is most commonly associated with open fractures, which are always treated with antibiotics. These are given immediately upon diagnosis in an effort to prevent the complication. Traumatic arthritis may occur if a fracture involves the joint, because malaligned joint surfaces block motion and produce excessive wear on the articular cartilages, causing damage to the chondrocytes. Immobilization by a sling or cast after a fracture can rapidly lead to disuse atrophy of the muscles. This atrophy is simply a loss of muscle bulk, and this occurs when the proteolytic systems are activated and contractile proteins and organelles are removed, which results in shrinkage of the muscle fibers. Prolonged disuse atrophy can lead to muscle contractures. A contracture is a shortening of the muscle and the tendon that attaches it to the bone. Immobilization after a fracture or its surgical repair is the most common cause of contractures. The muscle length shortens because of the loss of sarcomeres. Joints are classified according to the degree of movement that they permit. Joints are classified as fibrous, cartilaginous, or synovial. This is based on the connective tissue that holds the joint together and the presence or the absence of a joint cavity. Fibrous joints are joints where articulating bones are held together tightly by tough fibrous connective tissue. No joint cavity is present. In cartilaginous joints, articulating bones are joined together with hyaline or fibrocartilage. Cartilaginous joints are of two different types. One is synchondrosis and one is symphysis. A synchondrosis joint is also sometimes called a primary cartilaginous joint. This is where a plane of hyaline cartilage joins the articulating bone surface. A symphysis or secondary cartilaginous joints are permanent and slightly movable joints. The prominent examples of the secondary cartilaginous joint are the pubic symphysis and each of the intervertebral articulations of the spine. Synovial joints are the only joints where the articulating bones are separated by a fluid-filled joint cavity or the synovial cavity. These joints are typically reinforced by ligaments, which are cords of dense, regular connective tissue that extends across the joint from one bone to the other. Also commonly present around the synovial joints are the bursa and tendon sheaths. The bursa is a small, flattened sac filled with synovial membrane and lined with synovial membrane and filled with synovial fluid. Bursa provide cushioning between bones and the softer tissues that overlie them to protect the soft tissue. The meniscus is a crescent-shaped fibrocartilage pad that partially divides a joint cavity. These are various common joint movements. Additional joint movements. A strain is a stretching injury to a musculotendinous unit. This can result in small tears in the muscle or the tendon, leading to limited amounts of bleeding, edema, and an inflammatory response. All of these can produce pain and stiffness. Strains commonly occur in low back, neck, elbow, shoulder, and foot. The tissue repair takes place relatively quickly with a short period of rest. A sprain involves the tougher ligamentous structures surrounding the joint, and there is increased pain and swelling. This takes a longer time for it to subside. A sprain is a stretching or tear of the ligament. Ankle sprains are the most common sports-associated injury. Ankle sprains are graded according to the amount of injury. A grade 1, the ligaments are stretched or slightly torn. A grade 2, the ligaments are partially torn. A grade 3, the ligaments are completely torn. Sites of ankle sprains and the ligaments that are involved. A is a lateral ankle sprain, and this is the most common form of ankle sprain. The knee is the largest and most complex joint in the body. It is actually a compound joint consisting of articulations between the tibia and femur and the patella and femur. This is called a hinge joint. An illustration of the knee anatomy. The stability of the knee depends on the multiple ligaments and muscles. The ligaments allow the hinge actions of flexion and extension, but inhibit forward, backward, and lateral movement. The surrounding muscles and tendons provide stability in varying degrees of flexion and extension, while the medial and lateral menisci ensure an efficient transmission of stress through the joint with frictionless movement. Back pain is a common injury that can have many different causes. It usually is the result of overuse of muscles and resolves over a relatively short period of time. However, back pain can be caused by significant pathology like scoliosis, compression fractures, neoplasms, spondylolisthesis, osteomyelitis, osteoarthritis, osteoporosis, cauda equine syndrome, and various other forms. The first stage of the degenerative process of the spine is disc degeneration. As the disc protrudes, it narrows the spinal canal and it impinges on the nerve roots. This causes pain. It can also allow the pain to radiate into the arm or the leg and can be motor, sensory, and also have reflex changes. Cervical nerve root compression can present as neck pain that limits motion and is worsened with extension. The pain may radiate down the arm to an area innervated by the involved root. Motor deficits can also occur with the deltoid and biceps brachii affected by a C4 to C5 or a C5, C6 herniation. The triceps brachii and multiple wrist extensors are affected by a C6 to C7 herniation. And the intrinsic hand muscles and wrist flexors, along with flexors of the ring and little finger by a C7 to T1 herniation. The biceps or triceps reflexes may be decreased. The bilateral and generalized weakness of the arm and hand may occur. There may be leg weakness if the spinal cord itself is actually compressed. Cumulative trauma disorder is also known as repetitive stress injury. These are temporary or permanent injuries to muscles, nerves, ligaments, and tendons caused by doing the same repetitive motion over and over. Symptoms may include tenderness, aching pain, cramps, stiffness, tingling, numbness, or swelling. Various examples of this disorder include tendinitis, tendinosis, rotator cuff syndrome, carpal tunnel, cubital tunnel, bursitis, and patellofemoral syndrome. Median nerve compression in the carpal tunnel due to repetitive motion at the wrist constitutes most cases of carpal tunnel syndrome. A compressive neuropathy secondary to occupational exposure. The prevalence is higher in women, especially after menopause, and it also increases with age. The median nerve is both sensory and motor. Ulnar nerve compression at the elbow results in cubital tunnel syndrome. The subcutaneous location of the ulnar nerve posterior to the medial epicondyle of the humerus makes it vulnerable to acute and chronic injuries. Lateral epicondylitis is also known as tennis elbow, and it is a painful condition involving the tendon of the extensor carpi radialis brevis. This attaches to the lateral epicondyle of the humerus. Tenderness is present over the lateral epicondyle. Trigger finger occurs when there is a disparity in size between the flexor tendons in the hand and the first annular renacular ligament, which overlies the metacarpophalangeal joint on its palmar aspect. The bursa are small synovial sacs located between tendons, muscles, and bony prominences. The function of the bursa is to separate, lubricate, and cushion structures. Repeated trauma of the bursa can lead to an inflammation. Hip bursitis, also known as trochanteric bursitis, is a common type of chronic hip pain. This pain is typically worse at night and exacerbated by lying on the affected hip. Thoracic outlet syndrome is a complex neurovascular disorder of the neck, shoulder, arm, and hand. The three sites of compression are the costoclavicular space between the clavicle and first rib, the interscalene triangle between the anterior and middle scalene muscles, and the intrapectoral space between the pectoralis minor muscle and the coracoid process of the scapula.